Hi, I'm Britta Conroy Randall from the 92nd Street Y. Welcome to Lessons from the Front Lines of the Pandemic. As our city and nation commemorate 2 years of crisis and losses from the coronavirus pandemic, we're glad you could join us for a behind-the-scenes look at what happened and why, from intensive care units to research labs. The 92nd Street Y is proud to present this program in collaboration with Mount Sinai as part of our long-standing commitment to the health and well-being of our community. Thank you for joining us.
As we enter year 3 of the COVID-19 pandemic, we have the occasion to both look back at where we've been and look forward to where we're heading. And that's what we're going to do tonight with this panel of experts who's been at the center of a really extraordinary COVID care and science response. I'm Deborah Schupack. I'm a writer who's had the privilege of getting an inside look at how the Mount Sinai Health System fought the COVID-19 pandemic. I've spoken with more than 100 Mount Sinai healthcare workers, including the 3 panelists here tonight, and captured their stories in a new book titled Relentless: How a Leading New York City Health System Mobilized to Battle the Greatest Health Crisis of Our Era. We have a great prism of expertise here tonight from the front lines of science and medicine, people who worked around the clock and at the edges of human endurance to care for patients, to mobilize the spaces, staff, and resources needed to deliver the care, and to answer key scientific questions about the virus to advance that care in real time. David Rich is the president of the Mount Sinai Hospital and Mount Sinai Queens. David was at the nexus of science and medicine, really conferring constantly with clinicians and researchers to make sure observations on the hospital floors and findings in the labs work together to help patients in really urgent need of treatment. Jessica Montanaro is an ICU nurse at Mount Sinai Morningside, who has been at the center of caring for critically ill COVID patients since March 2020, and caring as well for her colleagues, critical care nurses and other nurses as they navigated through the most stressful times of their professional lives. And Florian Krammer is a virologist who's been at the forefront of insights into SARS-CoV-2 antibodies, our own body's fighting force against COVID-19. Very early on, Florian developed an antibody test that looked for and importantly quantified antibodies in the blood of people who had had the virus. And the test quickly became the gold standard and led to a number of clinical and research breakthroughs. He's also helped make virology more understandable worldwide on social media in a number of languages, and even in a 138 tweet long tweetorial explaining vaccines. So thank you all for being here. I wanted to go back to the early moments, back to 2020, even maybe into 2019. If you could each sort of start us off with an early unforgettable moment when you realized the weight and the urgency of what was upon us and what your role might be. Maybe starting with Dr. Rich.
Very good. Thank you. Thank you, Deborah. One of the key moments for me was actually a dinner with friends from the Iranian community on February 29th. So it was Leap Day of 2020. And at that dinner, I got a call from Dr. Gopi Patel, who's the head of infection prevention for Mount Sinai Hospital, saying that it's here. We have 2 patients, physicians, who had traveled to Iran and they returned and now they have symptoms of COVID. They're going to come into our emergency department and be tested. And that was the moment where it just became real. Because until that point, we thought that, well, it was in Europe. It, of course, had been in China. And it was something that, was still theoretical for New York. But at the moment it became real, I think all of us understood that our lives were about to change in a very material fashion, and that we would be challenged in ways that we couldn't at that moment truly understand.
Thank you. Jessica, do you want to talk about a moment that sticks with you?
Yes, thank you so much, Deborah, and to everybody, and I'm grateful to be a part of this. I have several, actually. I'll try to keep them very short. It was actually late January late January, early February for me, and my parents were in Italy. It was common for them to go there and stay there for several months every year in their retirement. And at that time, Italy was starting to close down because of COVID. And I vividly remember having conversations with them about whether they should come home early or not. And they did. They came home. They were one of the last flights to leave Italy and get back to New York without having to quarantine at an army base. And even though they made it home and they quarantined themselves, it was still very much on the periphery for me. It didn't feel real, Fast forward until March 2020, it was March 17th to be exact. We got our second COVID patient into the ICU. And he was different because he was awake, he was alert, he was oriented, he was talking, he had difficulty breathing. He was on a non-invasive ventilation, something called BiPAP, struggling to breathe. And it was at that moment, I was in full head to toe PPE. I remember closing the glass door behind me and realizing I could die. I really thought that I could get this. We didn't know what it was. I'm sorry, this gets a little emotional for me. What made it even more scary was that he was on a device that, while it was forcing air into his lungs, the air he was breathing out was being forced out. So it was aerosolizing in the room. And he was terrified. I was terrified, but I couldn't show him that, and I couldn't tell him that. I gave him a thumbs up right before I was leaving my shift. And I came back to work 2 days later. I was off for 2 days, and he looked half dead when I came back, just 2 days.
Thanks.
And I want to just preface this with saying that he did survive. And he and I have spoken extensively about this, so I'm not being insensitive when I say these things about him. But he was mechanically ventilated. He was paralyzed. He was sedated. He was on multiple drips supporting all of his organs. And I remember standing outside his room, just being stunned, thinking, like, is this what COVID does? Like, is this what are we fighting against? It was terrifying. He has gone on to be nicknamed Miracle Larry by New Yorkers, and he is a miracle. We frequently locked eyes before that happened, so we had a personal connection, I felt like. But it was extremely terrifying for me. And then I would say it was about 1 to 2 days after that the ICU just exploded. It was a tense, chaotic environment. Staff was running. We had equipment everywhere. I mean, I've never in 20 years of nursing have seen pumps outside of rooms with multiple feet of extension tubing running from the patient to outside the room. It was surreal. And then there were just 2 quick other profound moments for me that will stay with me the rest of my life, that I think, signified for me that we were up against something terrifying, which was early on in the pandemic. We had learned that one of our colleagues had passed away, a nurse who was fighting COVID at one of our sister hospitals of Mount Sinai. And many of the physicians and nurses had known and worked with this person. And that was a sobering moment for us as staff. And I'm the charge nurse, and I remember calling a huddle to address it because people were hearing about it. And we all huddled together, and there was chaos going on all around us, but it was like we were in a bubble. And we cried, we were scared. We held a moment of silence for him. And that was a significant moment that I remember, wow, this is something unprecedented. And then just finally, I'll say we had a colleague of ours in Mount Sinai Morningside, an emergency room nurse who got sick and was admitted to our ICU. I'm friends with him personally. And I remember going into his room, caring for him, and thinking to myself, why am I not in that bed, right? Why am I not sitting there and just talking through mortality with him? It was it was surreal. And I knew that we were up against something we had never seen before.
Thank you. And we'll dig into those sort of new ways of working soon. I just want to hear from Florian, if you may take us back earlier, I think, because you knew what was on the horizon before a lot of people did.
Yeah, I'm working a lot on influenza, right? And so you keep, as an influenza researcher, you keep your eyes open about outbreaks of pneumonia, specifically in Southeast Asia, right? And I heard about this outbreak on December 31st of 2019, and I remember I went to a New Year's Eve party on the west side, and with some people there I discussed this, and I was like, yeah, if this would be something bigger, we're not prepared for a pandemic, right? At that point I didn't think too much about it, but then 10 days later the sequence was released. And so I always tell my students that, or used to tell my students that in 2003 with SARS coronavirus 1, we were very close to a pandemic. There were 8,000 cases. There were outbreaks in Canada already. 800 people died. And then on January 10th, the sequence was released. And, I looked at the sequence and this looked like SARS coronavirus 1. And I really panicked. And that together with, the developments in Wuhan, where they didn't get the virus under control, where people started to die. I was really in a panic mode in the beginning of January. And I channeled that into preparing for, maybe having to deal with this virus here in New York.
So I'd like to now turn to sort of how you guys got through it, how you and your colleagues mobilized to fight the pandemic. And just as a brief snapshot, to set the scene, 2 years ago on March 29th, 2020, the Mount Sinai Health System was caring for 1,082 COVID patients, 204 in ICU, and was 9 days from its peak of well over 1,600 COVID patients. But that day, actually March 29th, Mount Sinai Brooklyn, which was the earliest and hardest hit, was at its peak. The 212-bed hospital was caring for 174 COVID patients, so really stuffed to the gills. We're far from that now, but I'm going to ask you folks to take us back there. And maybe, Florian, if we could continue the conversation with you to talk about sort of what you dug into in your lab, and sort of the pace at which you felt you had to work. And then I'd love to get the clinical side of things as well, equally fascinating.
We started to get prepared, right? And that, in my case, means making reagents for assays that we might want to perform for analyzing people's immune responses, setting these assays up. We also worked a little bit on looking at how to detect the virus. I had early on conversations with colleagues, specifically Viviana Simon here at our department, for banking residual samples to see if maybe something was already here earlier. So we started all of these developments, and we also started to share reagents massively, right? I think we sent out packages with reagents to more than 250 labs and hospitals globally. So all of this started, and in a way that helped me to channel my anxiety. But it was frightening to see how the virus came up and really spread in Wuhan. And then you had first cases already outside in Thailand, for example. And all of a sudden we had a huge outbreak in Iran, and then Italy happened, right? So it came closer and closer, and it was terrifying, but it motivated me to work. And a big part of my lab basically jumped on this too. Now, of course, when the wave hit New York, things got very complicated, right? We basically switched a lot of our regular work to SARS-CoV-2, and then we also switched routines, right? People put in a lot of work. We tried to get everybody into the lab safely. I've technicians, students, postdocs who live in Brooklyn, who live in New Jersey. So we were able to arrange Uber trips for them so that they wouldn't have to take public transport. And yeah, it was a very tense situation. And the good thing is that in this initial phase, we could keep everybody in the lab safe too. So we didn't have any infections here, and everything was running smoothly. But yeah, it was a lot of work, and I'm happy everybody was motivated.
Yeah, okay. David and Jessica, on the clinical side, I think we'll hear a lot about that urgency and that fear and that teamwork too. So maybe if you could talk about how you did your work, what the changes demanded, and sort of a snapshot of how you got through it.
I'll note a couple of things, Deborah. First is that related very much to Florian's work, we realized early on that laboratory medicine was going to be one of the most important things that was going to be able to support our clinical teams. So there were two efforts that happened concurrently that I think were very important that I want to highlight related to laboratory work. The first was that the research assay that Florian developed to measure antibody levels against the virus, in other words, the human's immune response after infection, that was in a research laboratory. And within, it seemed like days, we had Florian's team in the regular laboratory that serves the patients of Mount Sinai Health System, developing this test and reaching out to the regulatory authorities at New York State that allowed us in extremely rapid fashion to have approval to use this test for clinical purposes. And that leveraged our ability to take our own patients who had recovered from COVID 2-3 weeks out in their recovery and work with them to go donate their plasma. And in our hands in the early days, it did look like the convalescent plasma effort was very successful because this was different than the larger national effort. We were giving 2 units, and every patient that donated plasma that ended up coming to Mount Sinai, we knew that that patient had a very high level antibody response. And so that was critical, and it really brought science and clinical medicine together in a very meaningful way. And people responded to what this really was, which was a warlike situation, by throwing everything they had at it. There was energy and there was fear, but sometimes the two can work together, very much as Jessica was saying, how we got motivated on the clinical side. So the other key thing that I'll mention is that on the hospital side, people were absolutely devoting themselves. It didn't matter if it was a pediatric cardiologist or an orthopedic surgical resident. They came out of the woodwork to help us on the floors caring for patients. Everyone learned about respiratory therapies like high flow nasal cannula, what Jessica referred to earlier, the non-invasive ventilation or BiPAP. And clinical protocols were developing extremely quickly. And I couldn't be prouder of the teams that worked closely with scientists in the school and clinicians in the hospital, doctors, nurses, respiratory therapists. Everyone came together and did what needed to be done at the same time that we were focusing on really trying to understand scientifically what was happening so we could make meaningful contributions.
Right.
Thank you.
Yeah.
I can share with you that, obviously my experience is a little different because I would, Dr. Rich just said war zone, and that's exactly how I described it to my parents. I'm in a war. I remember saying that. But the level of collaboration was just unparalleled from what I had ever seen. We were no longer physicians and nurses or medical and surgical teams. We were one staff doing each other's work. I have so many examples of that we couldn't even cover it here. But we had to change practices on the fly due to the volume that was coming in. For example, like how we proned patients who needed that intervention immediately, how we positioned our equipment, right? Or how we changed how we sedated and paralyzed patients in the face of medication shortages and concentration changes. There were times that I was the only nurse in a room full of surgical doctors who had not ever used prone procedure in this environment, right? Not in the OR, but in this environment. Mm-hmm. And I was leading them through step by step how to do this with me. And they, would follow my lead. Physicians would be in isolation rooms, and the nurses, like myself and my colleagues, would be standing outside these glass doors, screaming over the noise of the HEPA filter, telling them how to change the pump, right? So they could adjust the rate. And it was just unbelievable.
Because that's something that they don't usually do.
No,
You usually do, right?
Absolutely, absolutely. There's two specific memories that stand out to me that I think can give you a good example. There was a surgeon who was caring for COVID patients, because at that time, all these doctors from all over our system were coming in and just, helping with the volume. And he was in the room, and I noticed that the garbage was full because of all the doffing of the PPE. And, we wanted to safely do that. So I remember knocking on the glass and pointing to the garbage and being like, could you change the garbage for me? We need to get this changed. And he did it, he just took the garbage out and he changed it for me. And it was those kind of things that will stick with me forever. But I have to say also that there was no professional filter. What I mean by that is we were all just kind of barking at each other, our needs, orders, commands. No one took anything personally. No one was offended. We were just in go mode, together, right? So it was, I have to share this one thing, because I think this will give you an example of the teamwork, was that a very seasoned nurse who was in the last year of her nursing career, about to retire, was sitting at the computer. It was the end of the shift and she completely broke down. And it was her third patient that had died that day. And she looked at me and said, I cannot put another patient in a body bag today. And there was an anesthesiologist that we work with who was walking through the unit, and he stopped and he hugged her and he just comforted her. And everything was blurred. The lines were blurred. And those of us who had the strength picked up the work for her at that time. And we did that often.
Yeah.
I'd like to raise another thing, if I could, Deborah, for a moment.
Sure.
The way that people contributed was really monumental. The scientists in the laboratories include, of course, full professors like Dr. Krammer, but also postdoctoral students, graduate students. They came into the lab and they helped us as laboratory technicians. The surgical technologists, the people that assist the surgeons in operations, since we weren't doing normal elective surgery, came to the intensive care unit, and very much as Jessica described, they helped innovate and develop safe ways of turning patients into the face down position, the proning, which, speaking as an anesthesiologist who's done proning multiple times in my career, it's a very dangerous process, especially for someone who is unconscious and paralyzed, because they cannot protect portions of their body that could be injured by the pressure. And the other thing I want to talk about are the medical students that worked remotely to contact our patients, to get them to come in for antibody tests, sending them and coordinating with the New York Blood Center so that they could donate plasma. Other groups of medical students became ventilator assembly technicians. Mm-hmm. And in our medical school library, they were putting ventilators together, and then they were being shipped all over our health system in 4 out of the 5 boroughs of New York City. And this home front, if we want to use that war metaphor again, was very much supported by everyone. And so there were so many of these examples, and all of them, frankly, made me feel wonderful to see just how people would contribute at a time of crisis. And then the sad side, Jessica has pointed out just how much stress people were feeling. I talked to so many physicians who turned into surrogate family members. Mm-hmm. There was a very high death rate. And there were, for example, people who wanted prayers said shortly before a family member would die. And our staff stepped in and performed that function. They held hands, they held up FaceTime phones or other forms of communication so patients could, talk to their families, or families could see their loved ones before they passed away. And this was a remarkable time in our lives, hopefully one we never have to repeat. But the tenacity of our staff And the strength of the human spirit came out in so many ways.
Yeah, those are stories that are just amazing to hear. I'd like to sort of pivot and take this conversation forward, mindful of what you went through, accomplished, and were challenged by, and talk a little bit about lessons learned, about what of these new ways of working you are going to carry forward. I know, Florian, you had said, when you were learning about these new, the pneumonias, we're not ready for this. And I'd love to hear a little bit more from all of you about how you're working now and how it is informed by the pandemic, and how it might stand us in stead for the next.
I think we've learned about another anesthesia principle I'll talk about, vigilance. We always talk about that in my specialty. A lot of the logos of the organizations have vigilance on them, and lighthouses, things of that nature. And I think we've learned that we're a global community, and that scientists like Florian Krammer that are watching what's going on around the world and quickly responding to changes that we see, reacting and thinking at the molecular level, and then translating that to the bedside. I think we're much better at that. And I think that the lesson that we take away is this: pandemics usually do last for years. It'd be wonderful if we're done with it in New York, but that's unlikely to be the case, even though we hope that we certainly never see anything as bad as we did in the early days. But we're different. We think differently. We're more prepared. We understand the playbook for how to respond to the unthinkable. And we've learned how to be stronger people, stronger physicians and nurses and scientists. And I think those are the key differences that I see.
Yeah, so I can just echo what Dr. Reich said. I think what we saw, and this was a very interesting experience for me, when this really started, you saw that all of a sudden the clinical side and the research side worked together seamlessly, right? And this continues. There are so many connections that have been made. There's so much research now going on both sides. We continue to do these things. I don't think we'll stop talking to each other and collaborating. And I think that is something that's really important moving forward. And yes, the other point is really, we know what we need to do if this happens again. We know that locally. I think Mount Sinai was as prepared as Mount Sinai could be prepared at that moment, and I think we did a really fabulous job as health system, as a research community here. The problem that I see more is, are we prepared as a nation? Are we prepared as a global community, right? And not just research, but society as a whole for a new pandemic. I think that's also something that we need to ask ourselves, and that we need to plan for in the future, because this is not going to be the last pandemic. It's likely that in our lifetime we'll experience one or two more. And so I think we need to get prepared for that. But we learned a lot, and I think this will make things much, much easier in the future.
Is that, Florian, because of the collaborations, because of the science we learned, because of, we really worked out of a void and into something, into some knowledge, the pace at which science could move with the emergency use authorizations, because of the public awareness. What do you think stands us in better stead?
There's a few elements, right? The first one is the collaboration and this working together, and this really gives a lot of synergy. And the other point is people have now gone through that and know that they can do it again. And they know that if we have to respond to something like that again, we will do it and we will succeed, right? And that's also a very important point, I think. And then, of course, there's a lot of things that we learned on the biomedical side that will make responding to a pandemic easier next time. So, there are many different aspects to that, but I think, as I said, we learned a lot, and it will make it easier to respond to similar crises, but also to smaller crises in a more efficient way and quicker.
I'm going to amplify a little bit, if I could, Deborah, on what Florian said, because one of the key things is that the leadership of Mount Sinai is such that we don't know where the hospital ends and the school begins. It's one of our great strengths. And our dean, Dennis Charney, at the very beginning of the crisis said, there are no silos. We all work together. And there's a very key example of how we've now changed, in that we had a data science group that worked on developing clinical decision support tools, for example, predicting who has malnutrition and needs a dietitian's assistance. And we had a great group that was also working on genomic analyses, moving us towards an era of personalized precision medicine. And of course, all of the resources in Dr. Krammer's group and related groups that really studied microbiology. And this came together as a clinical intelligence group, is what we started to call it, so much so that we've now created a Mount Sinai Clinical Intelligence Institute, with the concept that the information that we've gathered, the genetic information on thousands of COVID patients, the information in the electronic medical records that are accessible by data scientists in ways that could never be done previously. One of the largest autopsy collections in the world, because we had such a large health system, which sadly so many deaths early on. When we put all that information together and we learn how to collaborate more effectively, this is a real game changer for us.
Yeah, I wonder if you could talk about, this is something that we maybe take for granted, but if you could talk about the sheer, at the beginning, how you seasoned clinicians and scientists did not know. The depth and level of what we didn't know was astonishing. And I think we maybe forget that now because we've learned so much in terms of treatments, in terms of what COVID was doing to the body. But if you could talk a little bit about just the idea of working without that knowledge and then putting these things into place, the real need for them was astonishing because of what we didn't know.
I'll respond by saying that with the conclusion is that the challenges changed every 2 weeks. That was my sort of rule. For 2 weeks, I was searching for reagents from the scientific laboratory so we could do a homegrown test for the presence of the COVID virus, SARS-CoV-2. And then 2 weeks later, we were trying to use the commercial tests to do the same thing. And then, 2 weeks later, we were worried about running out of ventilators. So we were coming up with innovative ways of potentially even splitting ventilators between two patients. And then we were weeks later worrying about long COVID. How are we going to treat people who have these persistent symptoms? And so as long as we understand that the challenges presented can be, temporal and fleeting in nature, but that the way we responded to crises could evolve in very profound ways. I think that is a key lesson from the early part. Not knowing is the nature of science. What do? We always are trying to learn more. We had, through the global communications, especially through colleagues, again, less so in Iran, but more so in Italy, we were getting information from the intensive care leaders in Italy about just what was about to descend upon us. So we had some advanced knowledge, but then we had no knowledge about treatments because they were too overwhelmed to really come up with treatment paradigms. And so I think that's where Mount Sinai was able to contribute in a very meaningful way, such as the use of blood thinning drugs to reduce clots that were forming and killing our patients. And the use of this technique for blood thinning, for anticoagulation, has persisted. And I think it was one of Mount Sinai's major contributions to the global fight against the pandemic.
If I could just say, Deborah, I think it's so interesting to sit here just knowing what I was going through on the front lines and hearing all the backstories of what was going on behind the scenes. And I think that's what's phenomenal here, right? And it's interesting you brought that up, Dr. Rich, because I remember, we would put people on slow dialysis at the bedside, and we were clotting constantly the cartridges, and we couldn't understand what was happening. And it was like this over and over. And, what have we learned? We've learned so much better the associated complications with coagulopathy and thrombotic complications with COVID. We had no idea what was going on in the beginning. And there's so many treatments now that we can anticipate. We've learned how to, control the environment in a way that is less chaotic than it was during that first surge. And I have to say that was truly evident in the subsequent surges that we've had. We don't have pumps outside the rooms anymore. It doesn't feel, it's definitely hard work, and it's not easy, but it doesn't have that same chaotic warlike feel that it did, because we have learned so much. And it's interesting, it's interesting how we all have different aspects of this, because one of the things, and I'm just going to talk more about the clinical side, that I think we didn't get right in the beginning, and it wasn't because we didn't, it's not medical related, but we didn't do this on purpose. We didn't connect families the way we needed to in the beginning. And again, it was not an intentional oversight. It was just that we were so overwhelmed, and I don't think we really had good systems in place to do this. And as I think I dubbed them the hell weeks, the 8 weeks that were the most horrible went on, that became very important to frontline clinicians because it created a lot of moral and ethical distress in us to have patients be in their most critical moments or in their last moments without their family at the bedside. And, we did it through iPads and FaceTime and Zoom and I think that, aside from learning and anticipating now the cascade of events medically that will happen in a COVID patient, which, we're so good at, I think right now, doesn't mean outcomes will always be different, right? Because it's still COVID. But I think the human side is somewhere that we got a lot better at, especially in the ICU. I had it was probably several months. It might have even been, it was towards the end of the first surge. And we had a 50-year-old woman come in who her husband and her teenage daughter were at home with COVID, and she was on BiPAP. And, it was only a matter of a couple days when she decompensated. And as we were getting ready to intubate and sedate, I just knew instinctively that we had to get her connected with her daughter before that happens, and I grabbed her phone and I asked her to point to her daughter's number to put her on FaceTime. And I was translating between the two of them, the I love yous and kind of explaining what was going on. And I'm not the only one. I mean, my colleagues across the board have done such significant work that way to connect families. That is something, I feel very proud of, because that was very difficult for families and for clinicians to watch.
And because families were not allowed to visit, because in the early days, there was that no visitor policy at Mount Sinai and everywhere else.
Everywhere. It was everywhere. And not only not visit, but, they would, drop patients off at the emergency room, and then we would call them that, they had passed. So it was very difficult. That was probably one of the most difficult things for us. Yeah,
that makes sense. And I wonder, Florian, if I could ask you, as a scientist, how does what you're hearing from the floors sort of motivate the work that you do? And could you talk a little bit about how you link with clinicians back and forth, maybe an example or two, so we can sort of see it in action?
Yeah, of course. I mean, just in terms of what motivates you in a situation like that, when all of this happens, right? I mean, I had these moments. I live on the west side. I walk to work, and you walk to work. Nobody's on the street, and you see a field hospital in front of your workplace, right? It was a terrible situation, and in a situation like that, I have to be honest. As a scientist, I'm driven by curiosity, right? That's my main driving force. But that switched to just I wanted to serve, right? I wanted to help as much as possible, and maybe in some ways, help people in some situations. And so I think that was a big motivation to just help people in whatever way you can through research. And I think to some degree we succeeded with that. And I'm very happy about that. So but yeah, we started to talk to many people in the hospital on a regular basis. I remember Dr. Reich described that we had the first meetings with the pathology group here. The pathology department is in charge of the clinical assays, right? The first discussion about how to bring this assay now into the clinical research labs. I remember that two members of the clinical of the pathology department showed up in front of my office and asked if they could have my equipment because they needed to set up this test. And of course, we helped them and provided the expertise and so on and so forth. I was in constant contact, for example, with Anja Wannberg in the hospital to talk about antibody levels in people who were donating plasma, for example. There was a lot of discussions and a lot of communications with Judy Aberg's group in the clinical trial unit and so on and so forth. So we had basically connected daily, and specifically with the pathology department, there was constant communication, right? And then, when this work continued and the assay was set up in their department, these reagents were new. You couldn't buy them, right? So we had to make them in a specific quality. And I remember I was really getting very worried because we were making them day by day. And if you wouldn't make the reagents, they wouldn't be able to run the tests the next day, right? So I was getting very nervous to make sure that we have everything right, because not always when you do these research experiments or production runs for these reagents, for example, it's not always working out, right? And so there was constant communication. These are just some examples of how we interacted.
The reagents that were being used on the clinical side?
Yes, correct.
Yeah, so you were, I see. So with literally sharing your research in real time.
Basically, we stopped doing other things, and then we just made these reagents so they could be used in the clinical lab, right? At this point in time, you couldn't, as I said, you couldn't commercially get them, right? This was unique at this point in time.
Mm-hmm. Well, this is such an interesting discussion. I would like to talk about sort of where we are now, bring people forward where we are now in the hospitals, where we are with research, some of the sort of most salient findings and looking ahead, and where we are as a society here today. Maybe starting with how the hospitals look.
Well, from the standpoint this week, hospitals in New York State look great. I mean, there are very few patients that are admitted with COVID illness, and that's a wonderful thing. I think the challenge is that we've been there before. We've had a good summer in 2020. We had a pretty good summer in 2021. And I'm hoping we have a great summer in 2022. I think we all want to enjoy the summer. But winters with a coronavirus, as my friend Dr. Krammer has taught me, the seasonality is such that we just don't know if this is over. So I think the point is we can probably at the present time, with the input of public health officials, relax certain things, but I don't think we can step back from that vigilance principle that I talked about previously. We are unlikely to be out of this if we just look at history books and the normal duration of pandemics, but we don't know. We just don't know. And I think the point is that it's okay not to know as long as we don't let down our guard and we don't leave ourselves unprepared.
From my perspective, so this is a nursing perspective, I think that number one, just to speak to that vigilance principle, I think that we can still, continue to get the message out there about the importance of vaccines and the importance of following guidelines. I think that we have a tremendous role in that as frontline healthcare workers, which I'm proud to be, and spread that word. I think also as a country, not just New York, but as a country, we witness the tremendous value that, and this is my nursing perspective, that nurses bring to the healthcare system, and the need for an exceptionally strong nursing workforce. And I think that if we can continue to focus on that and develop that and collaborate with nursing so that it's even stronger than it was going into this pandemic, because it's no secret nationally, we've identified that there's burnout and post-traumatic stress, which is very real. I mean, it's very hard for me to talk about a lot of this even here. I get emotional. I don't usually delve into all these memories that I have, of all these stories. I think we have to put systems in place to we know that something like this is very potentially likely to happen again. Even though we've made strides. And I think if we strengthen our nursing workforce, I believe that hospital systems can get into this concept of like pivot strategies. And what I mean is, when we're expected as a healthcare system or as a nursing profession to kind of change course immediately in response to some, event happening, when we've done the work to make sure that that's really strong, we can focus on strategies to help us pivot in those times. But there is a lot of consequences that are still happening as a result of this pandemic that are very, very real in the nursing profession. I think even in the physician profession, I don't think it's limited to just nursing. I think it's across frontline workers, from all the trauma that we saw over and over and over again. And burnout is not just a word, right? It's a legitimate thing that I think I have witnessed, many of my colleagues and even myself have gone through, and we have to stay focused on that.
Thank you for that.
I'd like to point out again, to amplify on what Jessica has said, that early on, our dean, our chief executive officer, both incredibly famous academic psychiatrists, realized that there was going to be a tremendous burden on our staff and on society. And so we created at Mount Sinai the Center for Stress, Resilience, and Personal Growth, so that we had a mechanism both to support our own staff, making behavioral health services available, but also to study and to understand what a pandemic of this nature, what a stress of this nature on society means to all of us. And we have shortages right now in the workforce. They are real. And this amplifies the stress that we have, even at a time when the disease is not quite at the same level. We're not all scared we're going to, walk into a room, not have our mask on properly, get it and die. We're in a different phase, but that phase is still just as stressful in certain ways, because we wonder how we're going to have enough nurses on our patient floors to care for people adequately, because so many have left the profession and resigned or have moved to other states. And so it's a real challenge for us to manage this phase of the pandemic, which is so closely tied to that stress phenomenon, to that burnout phenomenon.
Yeah. It's the post in post-traumatic stress, sure.
Maybe I can also say a little bit about maybe where we might be going with this, right?
Yes.
So, vaccination became available, and this has helped us to build a powerful wall of immunity that we see now really reduces severe infections, severe outcomes. But the emergence of variants, which is something that was relatively unexpected, has also shown us specifically with Omicron that we cannot eliminate the virus, and we see breakthrough infections. They might not be severe, but we do see them. This tells us that the virus is not going away, right? We will have in the future to live with SARS coronavirus 2. It's not going to disappear. And of course, now it's really important to figure out how we can track these variants, how we can update vaccines, which new vaccines we can use to make sure that people stay protected. And as Dr. Rich said, we need to remain vigilant about increases in virus circulation, which are expected to happen in the fall and winter season, similar to what we see with influenza, for example. And while this might not be a pandemic situation anymore in the coming fall, we have to keep in mind that other viruses that circulate seasonally, even if they're not pandemic viruses, like influenza, can also do a lot of damage. And there's a lot of stress on hospital systems when we have a severe influenza season as well. And I think we'll have to continue to deal with that with SARS coronavirus 2. I think it's just really great that with vaccines and with immunity that people build, and also with better drugs that are now available, that we can really attenuate the disease and attenuate the epidemics that might come with future SARS coronavirus 2 variants.
Right. And so can you talk a little bit as a virologist about sort of that idea of moving from epidemic to endemic?
Yes, I think we're in that stage right now. In the UK, for example, the infection fatality rate, meaning the number that tells you how many infected people die, is now similar between seasonal influenza and SARS coronavirus 2. And that was really caused by widespread vaccination. And I assume it's similar in the US, although we don't have those numbers necessarily. And so once you're in that phase, again, the viruses will still manage to infect people, even if they're vaccinated. We see that now. It will keep circulating, and it will likely in the northern hemisphere become a seasonal virus. And again, we have seen that now, even in the last years, that there's an uptick in cases in fall, and we have a winter season, and the summers are usually relatively quiet, right? So I think this pattern will hold true, just that we might not have the same force of infections, of epidemics that we have seen during the last 2 years. And I think it will become something that will be relatively easy to manage. But again, as influenza tells us, there can be seasons where we still have a lot of severe cases, and where still there's a lot of pressure on the health system.
Thank you. And I wonder if I could sort of start closing the program by asking what you're looking forward to getting back to most that you haven't yet, or that isn't a regular part of your maybe professional day or personal day.
A family trip to a place so far away they don't speak English.
Is that on the horizon?
Verizon specific.
No, on the horizon.
Oh, on the horizon. I'm
Yeah.
not planning it this summer yet. I feel that most travel this year will probably still be domestic for my family. But I think the point is, when are we back to normal? Yeah. We're back to normal when we can travel globally and feel safe.
I have to say that, I have also stayed domestic, and, what I've noticed is that my youngest daughter plays volleyball, and we're a traveling team. So we're all over New York, and they have to play in masks, and we played for 12 hours a day, right? It's like an all day tournament. And so I can't wait to get back to life where, they don't have to do that. Although I will say, and our numbers are so down, I think we're doing great as New York. Just two players just recently tested positive, so, we still have to be vigilant, but I can't wait until I can send her out, without a mask.
what I'm really looking forward to is to get back full time on influenza research. It's also a very fascinating virus, and there's so much that needs to be done, and that's what I'm looking forward to.
So that constitutes a break for you, the influenza research.
A break from SARS coronavirus too, yes.
Yes. Fair enough. Fair enough. And we have just a few minutes left, and I wonder if there's sort of any final message, any final takeaway that you would want to leave us with about sort of where we've been, where we are now, and where we're going.
One of the things that concerns me was highlighted by a very recent publication in the Journal of American Medical Association. They looked at the number of people who died where it looked like alcohol was a contributing factor. And it looked, when you compare 2020 to 2019, that there were 20,000 extra deaths in the US. And when we would have a bad flu season in the past, if more than 10,000 people in the US died, I think I'll defer to Florian, but we said that was a bad flu season if we had that number of people dying. And also from opiate abuse as well. The number of deaths in this nation that reflect what's happened and the stress are things that concern me very much. And so beyond just what we do as virologists, as physicians and as nurses in caring for patients, we have an obligation as a society to harden our social support structure, because the effect on children who missed very important phases of their education, the effect on people throughout our society who are more vulnerable for either, whether it's a socioeconomic reason or due to structural racism. We have so much to heal in our society, and I hope that we learn from this pandemic and that we become a more effective society at treating the underlying problems that we have, and can learn from everything that we've been through.
Great. Well, that's a wonderful place, I think, to leave off. And I wanted to thank you all so much again for all your work and your time tonight.
Thank you.
Thank you.
Pleasure to be here with you.